This voiceover will cover sexual assault and rape. Let's start with some definitions. Sexual assault is forcing any type of sexual act on another person without consent, ranging from forcible kissing to fondling to penetration. So let's talk about what consent is. So consent implies to persons of appropriate age. Now this varies from state to state. So you need to know what the laws are in the state that you're working. Consent also implies to persons who are sober, cognitively intact, and that both say yes without any hesitation. Rape is the penetration, no matter how slight, of the vagina or anus with any body part or object, or oral penetration by a sex organ of another person without consent of the victim. So we can say that rape is a sexual assault, but not all sexual assaults are rape. Sexual assault is a violent crime of power, hate, violence, and aggression. Sexual assault can be committed by a stranger, an intimate partner, a family member, or someone else that the client knows. When sexual assault is committed by a family member, it's termed incest. Statutory rape is when an adult has sexual intercourse with a minor, regardless of consent. So even if that minor consents, depending on the state's age law, it is considered rape. So again, it's important you know the laws in the state you're working. I have bulleted New York State ages on this slide so that you can get an idea. Here are some demographics to look at. Don't get lost in the numbers, nothing to memorize here or anything like that. But just to give you a little background, in America, every 68 seconds, a sexual assault occurs, and 9 out of 10 of them involve women. 1 in every 6 American women have been the victim of an attempted or completed rape in their lifetime, and about 3% of American men have experienced an attempted or completed rape in their lifetime. So the deck is stacked against women, as we can see, but we can't rule out the men. They also can be victims. You know, remember that I said rape and sexual assault is not specific to age, gender, or race. And men that may not report an assault due to the stigma of the assault. And for many, they're concerned about the perception of homosexuality. All in all, rape and sexual assault tend to be underreported. So it's difficult to even know how accurate these statistics are. Sexual assault and rape are also very much under-prosecuted. Remember that rape can occur between married couples and intimate partners, and that's considered a form of IPV. There's also a little bit of data here about children and children who are victims of sexual assault. It's very alarming. So what are the clinical manifestations of a client who's been sexually assaulted? Well, that is inclusive of both physical and psychological findings. So we can see broken bones, head traumas, abdominal injuries are very common, bruising, lacerations of the perineum and anus. And there's also a risk for sexually transmitted infections and pregnancy. Psychologically, clients are often in shock, denial, they may be withdrawn, and they can have a whole range of emotions. So they may be calm, they may be tearful, they may be laughing, or they may be angry. And please understand that none of those signs is wrong, and none of them are right, and that everyone responds individually to sexual assault. Humiliation and embarrassment. We often hear that clients, particularly clients who are raped, say they feel very dirty, and they just can't ever get clean again. And very often they blame themselves. They think a lot about what I could have done differently so that this wouldn't have happened. This is my fault. If I didn't put myself in this position, if I didn't wear that particular outfit, if I took a ride home rather than walking home by myself, if I hadn't had something to drink. Psychological manifestations usually last about 2 to 3 weeks, but it's not uncommon to see them go on for months and years. And when that happens, we call that rape trauma syndrome. Let's talk a little bit about rape trauma syndrome. There are 2 phases. There is the acute phase, which lasts for about 1 to 2 weeks. And then there's also a long-term phase, which can go on, as I said, for weeks, months, even years. So initially in the acute phase, and know that Halter and Lewis conflict and contradict a little bit here in terms of what's an acute symptom and what's a long-term symptom. So I just kind of tried to put them together so they made a little more sense. But acutely, clients may be fearful. They may have a trust issue. They may be angry. Very common is insomnia and difficulty concentrating. They often have somatic symptoms, and particularly GI symptoms are very common. They have a feeling of powerlessness and self-blame. So these are some of the common things we see in clients initially, but we can also see these things in more of a long-term phase if they don't resolve. And so that's why your books kind of cross wires here a little bit. In the long-term phase, we see a worsening or an extension of what we saw in the acute phase. So we can see mood swings, very powerful flashbacks, intrusive thoughts. So what I mean by that is that they just think about the assault all the time, can't get it out of their mind. It just keeps playing over and over and over again. Irritability, anger, despair, hopelessness, shame, depression, substance abuse, and even suicide. So there is a very serious suicide risk for clients who linger in this long-term phase. So rape trauma syndrome is a form of PTSD. And things that we can do as nurses is to really set the client up for success. And this is in our advocacy, in our empowerment. So to tell a client, you did nothing wrong. This is not your fault. To really confirm and validate that with them, starting right at the very beginning, right after the assault. And then to set them up for success when they're discharged from the ED, to provide them with referrals, and we'll talk about that a little bit later, to ensure that they can get the help they need to move through these phases and back to a sense of recovery. And how we evaluate that in the long term, we look for progress. And the ultimate evaluation outcome is that the client can eventually maintain a long-term, intimate relationship where they experience enjoyable, consensual sexual activity. So I did, in the Voiceover folder, post a rape victim statement. It's a very powerful statement. We're going to watch a video about this case in class, and it really explains better than any textbook what rape trauma syndrome is like and the impact that the victim feels. So it's a PDF. It's quite long. It's about 12 or 13 pages. It's very thought-provoking. It's very emotional. It may be very sensitive. It's there if you'd like to read it and learn a little bit more about rape trauma syndrome, and I encourage that you do. But if you find it's just too sensitive and difficult to read, that's okay too. And we'll talk about it, summarize that whole case when we go to class. If you had the opportunity to read the rape victim statement, I think that you will agree how very important our caring, therapeutic relationship becomes with these clients. And so here are just a few key points to think about in that relationship. So when the client comes to the emergency room, we typically have someone stay with them, someone they trust and someone they feel comfortable with. And so this will help to support them and help to keep them safe. We want to be very careful to use non-judgmental language, and that also means your facial expressions, right? You don't want to look surprised or horrified or upset. The client already knows those things, but that's part of remaining non-judgmental. Remember, they blame themselves. Confidentiality is key. It's incredibly important in this very sensitive type of assault. It's a good time for nurses to really be present with the client and use their listening skills. Don't force the client to talk until he or she is ready, but when they are, listening is more powerful than anything else. They want to be heard. They need to go over and over sometimes what happened. Remember to affirm the client and stress that what they did or didn't do, they feel guilt about it, right? They feel guilt about the whole attack and the role they may have played in it. Stress to them that they did what they needed to do to survive and stay alive, and that was the right thing to do. Explain to them about rape trauma syndrome. Tell them what some of those findings are and that they're normal, and that in time they will get better, and that there are referrals that can be made, and let them know how they can access help. Ask permission for everything that you do with this client and go very slowly and carefully explain every procedure. This is really important in terms of them gaining their control back. Allow them to say no. There's a part of a procedure or an exam that they do not want to participate in, and that's okay. This is a very important role in the care of clients who have been sexually assaulted. Initially, when the client comes to the ED for treatment, the highest priority is to provide for their physical and emotional safety. So it's very important when they first arrive that you assess and treat physical injuries first. You may want to create a body map to document any injuries that you find. And this might be important later on if this becomes a legal issue and the client agrees to prosecute. Provide for their safety and emotional well-being. And so this is where on the last slide we talked about having someone stay with them, someone that they trust. So if there's a friend or a family member that comes with them, that would be a good person. In some larger facilities, they have a sexual assault advocate or volunteer that can come to the ED and stay with the client. If you suspect a drug-assisted assault, meaning a date rape drug that was used, you'll want to probably obtain urine and blood samples early in this process so that there is still evidence of these drugs in the system. If you wait till later when the examination is finished and you've done everything else, the evidence may not be present or as strong. You'll ask the client if they are willing to have a sexual assault examination where forensic evidence is collected. And this can be done by a sexual assault nurse examiner. This is a nurse with special and additional training in this area. And it can also be performed by a provider. But you must have the client's consent, and you can explain to the client why this is so very important, especially if they're going to prosecute. We'll talk a little bit more about this on the next slide. Your documentation must be very clear and accurate. You should document what the client says verbatim, especially thinking ahead to your documentation being addressed in a court of law. The client may need some prophylactic treatment in terms of sexually transmitted infection or an unwanted pregnancy. And so there's some teaching involved there. It's a good opportunity for teaching, and the client may be discharged if they request with the Plan B drug to prevent an unwanted pregnancy. And finally, you want to make referrals. Remember how important it is that the client move through rape trauma syndrome and come out the other side having made progress as a whole person. And so it's really important to give lots of referrals, social workers or a case manager, a crisis center. Remember the high risk for suicide, counseling, support groups. Arm them with as much help as you can to help them be successful as they work through this very normal process through this rape trauma syndrome. And most of all, follow your facility's protocols. So every facility has very detailed and exact protocols, especially if a rape kit is going to be collected. So to talk a little bit more in detail about the sexual assault forensic exam, or sometimes we call this a rape kit. The purpose of this is to collect evidence to prosecute the rapist. You must have the client's consent. They may not be sure about this. They may not be sure they want to prosecute. But it would be good to try to get them to agree to this. The rape kit can be held onto securely and confidentially should the client change their mind if initially they don't want to prosecute. Remember, there's that whole gamut of emotions they're going to have over the weeks that follow. So it's really important to try to encourage them to do it and support them through this process. It involves collecting all of their clothing, bodily fluids, samples, and taking pictures. It's really important that the photos are consented to, and again, that they're maintained. So again, here's where you use your facilities protocol, but usually a special digital camera is used that belongs to the rape kit. The pictures are transferred onto a drive that goes into the rape kit, and then the photos are deleted from the camera. When they collect body fluids, they collect from least invasive to most invasive. They proceed very slowly. They explain everything, and again, allow the client to consent or say no, and support them in their decisions. Again, the exam can be performed by a sexual assault nurse examiner. Again, most larger facilities have one, at least on call, a nurse practitioner, a PA, or a physician. Typically, when clients come to the ED, again, remember they feel dirty, they want to wash, they want to clean up. It's really important that you don't let them do that until after this exam. And the way that they proceed is generally to put a clean white sheet on the floor. They ask the victim to disrobe, and all that evidence is rolled up in the sheet and saved in the rape kit. This is a very difficult and emotional time for the client. And again, I can't stress enough that role of the nurse, caring, supportive, being an advocate for the client. And finally, there is some adjunct pharmacology that may be used for these clients. I'm sure that you've talked about most of these drugs already in your other mental health classes. Just important to know that they're used and what they may be used for. So benzodiazepines, remember, they're fairly short acting. They're very good in the treatment of anxiety. They may be prescribed for panic attacks. So when a client goes home, if they move into that long-term phase and they're having anxiety and panic attacks, this is likely to be prescribed for them. Remember that in the long-term phase, clients also may develop depression. And antidepressants prescribed for depression may also help with sleep problems, with insomnia. If a client continues to have flashbacks, those intrusive thoughts, sometimes violent dreams, a very small dose of an antipsychotic may be used to help them move through that period. And of course, we already talked about Plan B in the event that the client wishes to pursue pregnancy prophylaxis. This completes the voiceover for sexual assault.